Hi, my name is Jason Chandler, and I'm here to go over the ASH 2020 update on myelodysplastic syndrome for this conference. So just to review, age-related incidence of MDS is the most important risk factor. You can see as patients get into their 70s and 80s, the incidence of MDS goes up significantly. And when we're looking at these patients, we want to risk stratify them to try to decide how we're going to treat them. So most of you have seen this before. This is just the revised IPSS stratification system, and it uses cytogenetics, the number of blasts, and the number of cytopenias and low counts, and you get a score. So the very low and low you see are all 3 or less, high are 4.5 or higher, and then you have the intermediate group from 3 to 4.5. So the reason that's important is you can see those really stratify very nicely as far as survival on the left and freedom from progression to AML on the right. So the very low and the low, although not wonderful, they do pretty darn well compared to those with the blue and the red that their survival is really terrible. So when we talk about treatment, it's a very different process to treat patients with low risk MDS versus those with the higher risk. So first we'll talk about low risk. And when we say low risk, we're saying they do have dysplasia. Their cells are funny looking under the microscope, but they don't have many blasts on the bone marrow and their blood counts are not that low. Their karyotype or the molecular abnormalities are not as severe or negative. So that's ones that are, like we said, 3.5 or less. And for these patients, the main thing is to try to control their symptoms. We have ESAs or GCSF just to boost their counts, lenalidomide for some patients. We'll talk about Luspatercept, and then in the rare patients, cyclosporin and ATG. So Luspatercept is already FDA approved. It was presented last year at ASH in most of the bigger session. So this year it was a little less, but I wanted to touch on it since it is a newer drug. So there are this GDF11 prevents the maturation of red blood cells. And so Luspatercept, they call it a ligand trap. It kind of prevents this from occurring. And so Luspatercept is used for those patients that need transfusions with low risk MDS. So the Medalist trial was what the drug was approved on. And this is just looking at some of the data related to it in deeper form, looking at some of the reticulocyte count and other erythropoietin markers that would show why these patients are responding. So just to go over the study real quickly, this is the Medalist trial was for low risk MDS. And this is patients that had this low risk. They had to have less than 5% blasts. They could not be a 5Q minus. They had to be the very low, low, or intermediate risk on the IPSS. They did have to have ring sideroblasts, which is part of the package insert as well. And then they either had to be refractory or intolerant to erythropoietin stimulating agents, or they had to have high levels, which would be the ones that would be less likely to respond. And these patients had to have a requirement for at least 2 units of blood every 8 weeks to be eligible for this. And they had not had a previous hypomethylating agent or IMiD. So what they looked at were we know that it worked based on the drug getting approved, but this study was looking at some of the other markers and it said, why did it improve? So you can see on the left, this is the Luspatercept group, and on the right is placebo. So at baseline, they had erythropoietin levels of 220 and 215 for placebo. And after treatment, the EPO level went up. And for the placebo, it didn't. And the same thing for some of the other markers. You can see below the reticulocyte count actually went up in the treated patients, and it stayed the same in placebo. And then below that, the transfusion burden definitely went down from 11 transfusions mean down to 7, where in the placebo group, it stayed the same. So this is saying, why did they improve? And it's because it looked like it removes this block and differentiation of the red blood cells. and allows them to mobilize the iron and actually make blood. So this is looking at it in a little different way. It says the CB and the no CB. So CB is clinical benefit and no CB is no clinical benefit. So of those treated with Luspatercept who responded, those are the ones whose EPO level went up. And when it didn't go up, that's the reason they didn't respond. And then on the right is placebo. So it's kind of the same information, but looking at the responders, how they're different than the non-responders in the Luspatercept group. Same picture here. The two lines you see, the top one is the one that had clinical benefit, their reticulocyte count, and the bottom one is the ones that didn't. So basically, all this information is showing the mechanism of action and why Luspatercept seems to work in this population. So this is low-risk MDS patients. So it seems to allow some of these biomarkers for erythropoiesis, and it definitely reached its endpoint of reducing the requirement for transfusions. Those patients that were transfusion independent at 8 weeks was one of the endpoints that it did reach. So going on, there is this mutation that keeps appearing, SF3B1. And when SF3B1 is there, you're more likely to have MDS with ring sideroblasts. You can see the one on the top when SF3B is there. This is mutated. These patients, this is their survival, so they do better. And this is their risk of progressing to leukemia. All that to say, in these studies, the Medalist study, most of the patients treated had this SF3B1 mutation. And you can see 93% of the patients treated had the SF3B. So it doesn't mean you have to have it for the drug to work, but this is a population of good risk MDS that mostly have this SF3B1 mutation and ring sideroblasts. So they don't progress very often or quickly, but they live a long time, but they just need a lot of transfusions. And this drug seems to release that block. So there are other mutations besides SF3B1, like TP53, ETV6. You can see all these, AXL, EZH2. So these are all negatively impacting mutations. So SF3B1 is good. These other ones are bad. And so even though they're not included in the revised IPSS risk stratification, there are other factors like these that might help us put people in different groups. So that's low risk MDS. We talked about the treatments there, supportive measures, lenalidomide, Luspatercept. What about the high risk patients? So it's hard to know exactly how to split this, but this is one study that looked at patients that either did have an HLA matched donor or did not and had bad high risk MDS. So the patients that had a donor got transplant, that's the yellow line. And the one where they didn't have a donor, they just got hypomethylating agent. And so both of these curves look really horrible. You can see at 3 years, the number of patients that are alive is not that great in either, but it's better for allo transplant than with hypomethylating agent. So the question is, should we just treat everybody with stem cell transplant? Obviously we can't, and it has lots of risk side effects. So what can we do? Let's try to add something to azacitidine or hypomethylating agent. So this study looked at Pevonedistat with azacitidine versus azacitidine alone in high-risk MDS patients. So the mechanism of action is NED8 activating enzyme inhibition. It has to do with ubiquitination. So the thought process is if you can block this, you could potentially use it synergistically with azacitidine. So the study included high-risk CMML, low blast AML, and MDS, but this presentation concentrated just on the higher-risk MDS. You can see it was AZA for 7 days, and then days 1, 3, and 5 were the Pevonedistat, and they were looking at multiple outcomes, including event-free survival and overall survival. Just to harp on what we talked about earlier, some patients that are high risk MDS or low risk MDS can actually be bumped up with mutations. And so one model is the Cleveland Clinic model that uses this formula. And if you have certain mutations, they're good or bad and kind of bump it up. So it's you could use the revised IPSS, or you could use one of these newer models that uses mutations to kind of put people in categories. So the red curve is the two drugs together, the new Pevonedistat plus AZA, and the right is overall survival, and the left is event-free survival. So you can see they definitely do better with the combination drugs. And this is looking at it if you use the Cleveland Clinic model. So only picking those that are high risk based on using mutations in addition to the revised IPSS score. So in this situation, the curve split even more. It's just to say that sometimes we're not measuring who is high risk by just those other markers, that the molecular DNA tests are important. So basically 79% overall response rate, which was pretty much incredible. You can see the number of patients that it was about 3.8 months before CR was achieved. There was the time on study was dramatically longer for the combination versus azacitidine alone. This is also looking at, if they went on drug and they did better, did they need fewer transfusions? And they did in this situation. You can see 69% with the combo were independent of transfusion of red blood cells or platelets versus 47. And they were less likely to progress to AML. So basically, it worked for all the markers. It reduced their blast percentage, put them in remission. They didn't progress as often. So this is a pretty good combination of drugs that helped survival and event-free survival. So it's an encouraging drug, Pevonedistat, to be given with AZA, not approved yet. And right now, there's an ongoing phase 3 Panther study that will look at it. And hopefully, if it is positive, then it will maybe get approved. Here's another study that is the same thought process, but it's Venetoclax with azacitidine. So blocking BCL2 and AZA, potentially BCL-XL and MCL1. And basically this was looking at almost the same markers. It could be almost identical study. The ramp up was 2 different ones where they went up to different dosages and ended up picking 400 milligrams as the dose expansion based on the safety data. This was really a similar population. This is looking at some of the AEs, which we would expect with the Venetoclax if you've got any experience with it. This is interesting. You can look at the green are the ones that are good IPSS, and you can see that many of them have like this AXL and EZH2. So basically they're supposedly good, but they have these high risk mutations. So these are some of the patients treated, and these are all the different mutations for these patients treated on the study. Again, excellent overall response rate of 79%, not that different from the other combination. So this is Venetoclax plus azacitidine in high risk MDS patients. So you can see here basically this is just looking at all patients and those that were dose expanded for 400 milligrams and how close they were. So basically 400 milligrams was the dose they picked. And this is the top curve is showing patients that received a CR. Their overall survival was amazing. And basically, if you got a CR, you lived a long time on this combo. So this is a great combination. The Venetoclax is given for 14 out of 28 days. So basically, you give it just for 2 weeks on, 2 weeks off with the azacitidine, which is for 7 days. And it had a dramatic improvement in everything, just like the other Panther study. This has the Verona phase 3 study that hopefully will be coming soon. So basically, to review, we talked about low risk MDS patients and how they're completely different than high risk. Luspatercept is a great way to treat them. It releases the block on red blood cells so they can mature. There are different mutational panels that are not currently in the revised IPSS guidelines. In general, SF3B1 is a good one, and TP53, the other ones listed, including RUNX1 and AXL, are poor risk. So if a patient is a high-risk MDS patient, they have very poor clinical outcomes, with the only thing really working is Allo transplant. But new combinations are on the horizon. Venetoclax is already approved, so you might be able to get this, but it's not on label yet. And then Pevonedistat will be hopefully coming soon. So thank you guys, and look forward to any questions.